have a member who came from India and such an orthopedic surgeon to talk from orthopedic management in cerebral
Negative
palsy.
findings. Loss of balance is a negative finding. Spasticity is present. So I would like people to see what is present in cerebral palsy. What is present? Spasticity is, all of you can say present or absent, is present. Hypertonia is present. Balance is absent. Planning of movement is absent. Okay, so there are some things which are present, something which are absent. Strength is absent. Spastic muscles are not strong muscles, they are weak muscles, so strength is absent. So there are things which are positive and something which are negative. And it's important to understand when we talk of management, it's very easy to control which is present. If increase in tone is present, we can control it through medications, through botulinum toxin injections, through therapy, through tone inhibiting plasters. Okay. If contracture is present, we can correct it through surgery. If deformity is present, we can correct it through surgery. But if strength is absent, we have very little we can do about it. If balance is absent, we can do very little about it. If control is absent, we can do very little about it. So this is something which we all need to understand. What I'm trying to do in this presentation, which will be over next half an hour or so or 40 minutes, I'm just going to take one aspect of a child with cerebral palsy, and which is walking with a flex knee gait. You see many of children with cerebral palsy walk with their knee bent. Okay, so I'm just going to take one aspect and show you, how assessment makes a difference and how different children who are all walking with knees bent have to be treated in a different manner. Okay, so it's not one medicine which works for all. If you have fever, everybody is going to take paracetamol or antibiotics, but it's here the difference is in cerebral palsy, for the same condition the treatment will be different. The child is walking on toes, what we call it equinus. One child will be treated with therapy, other child will be treated with splints, third child will be treated with Botox injection, someone will have surgery which is on muscle, someone will have surgery which is on bones. So different treatments will be present for the same apparent condition. And why this happens, we are going to study. Okay, so first thing what we have to realize is that not everybody who walks with spasticity has cerebral palsy. And I want to give you example of these two children, one on the left, one on the right. Both were labeled as known case of cerebral palsy and were being treated for number of years as CP children. Okay, when I saw the child on the left, very intelligent, birth history was fine, but was walking with flex knee gait. And this child, when we investigated, we found out that his neck was stiff. So, Sunil very rightly said, it is not, you don't see only legs of a child who cannot walk. You have to see the child overall, and MRI done, and that MRI showed us that that child had compression in the cervical spine. So not cerebral palsy, compression in the cervical spine giving rise to spasticity. And he did not require surgery on the legs. Actually, he required a spinal surgery which made his walking pattern better. The other girl who was walking again with knees bent, we got a history that her sister also had same problem. When we asked a detailed history, we came to know that the child was walking normally till age of 3 years, and then slowly, progressively, she started falling. She had tightness in legs. She had difficulty in writing. And when we evaluated this was diagnosed to have hereditary spastic paraparesis, HSP. Okay, so this child did not require surgery. All she required is therapy and medical management and counseling to the parents that this is a genetic condition and it's not cerebral palsy. In both cases, they were brilliant children. Higher functions were normal. Speech and communication was normal. So, we came to know in today morning's talk that 80% of children with CP will have speech and communication problem. But if they are talking well, if their speech is clear, if otherwise they are fine, for a moment think that this may not be cerebral palsy. So this is the first lesson we are learning now. Second lesson we are learning is what has been already told in some of the talks, but I'm going to re-emphasize again that children with cerebral palsy change as they grow. Though by definition, what is definition of cerebral palsy? Anybody wants to tell me the definition of cerebral palsy? Anybody knows? So it is non-progressive disorder of motor tone and muscle tone and posture, right? So somebody would say that if it's non-progressively, everything should remain same as the child grows. Is okay? Can all of you hear me? Should I use this? Okay. I'll use this. Okay. So, though it is a non-progressive disorder, the same child, as they grow, the problems become different. Okay. So, if you see the child on the left, he is walking on toes, but that problem is because of spasticity. And we call it as a primary problem. And in that child, your treatment should be control of spasticity. If you lengthen muscles at that age group, it's not going to work. You have to control spasticity, and that control of spasticity will be through therapy, through calming down, okay, behavioral changes, through medications, through Botox, through plasters. Okay, there are various ways to control that, but other modalities are not going to work that well. When children have shortening, and that shortening develops over a period of time, the children with CP are not born with shortening. Why does shortening happen? Does shortening happen in CP? Do muscles actually shorten? Yes or no? How many of you feel actually in CP muscles shorten? How many of you feel they don't shorten? How many of you don't feel at all? No problem. So in cerebral palsy, muscles actually increase in length with age. It's not that the muscles are not increasing. Muscles increase in length, but they don't increase in length as much as the bones. Bones continue to grow in height. Muscles don't increase in length as much as the bones, and that's why you have relative contractures. It is relative shortening. It is not actual shortening. And this is something which is important to realize. As the child is growing and is spastic, if you control spasticity, there are less chances that the child will have significant muscle shortening. If you splint the children well, if you give good medications, if you provide therapy, then shortening can be prevented. Because once shortening happens, it is difficult to treat, and in the process of treating, you are weakening the muscles. So these are few things which are important for us to realize. Okay. So that is the second stage, which is muscle shortening, and obviously it will occur when the child is growing rapidly. More the child grows in height, more will be the shortening. And that's why shortening is generally seen between 5 to 10 years age, because children grow maximally during that age. After 14, 15, they don't grow that much, and hence further muscle shortening will not occur. So first 5 years spasticity, 5 to 10 years shortening, and after 10 years, what happens is the growth becomes mature, and bones get influenced by tight muscles. So joints undergo contractures, the bones bend, the bones twist, give rise to rotational problems, and that gives rise to the deformities, joint contracture, and what we call as the liver arm problem, which Sunil spoke about, liver arm problem. So these are the things, and that's why when it's shortening, you'll have to tackle muscle shortening. Muscles can be lengthened in two ways. They can be lengthened by increasing the muscle length by doing a surgery, or the muscles can be lengthened by shortening the bone. Okay, so there are two ways to lengthen muscles. Whenever there are bony deformities and joint contractures, muscle lengthening surgeries don't work. What you actually have to do is correct the contractures. You have to do an osteotomy, bone surgeries in the third stage. That is why you will see that if I have to summarize my talk in just 1 minute, I would say that when child has spasticity, control spasticity. When child has muscle shortening, do something to lengthen the muscles. And when child has liver arm problem, you require bone and joint surgeries to correct those liver arm to allow them to walk better. So we have two choices. I have told you summary of my talk, and we can end here, or we can continue. What what should we do? Should we continue or end here? All right. So we'll continue. So this is the circle I spoke about, and what I'm going to do is with this now. Directly we'll go on to the cases to see practically how this works. Okay, practically how this thought process works. I'm just going to skip these slides because they have already been covered by Sunil brilliantly. I'm just going to take you through this one slide particularly, which is very important to understand a concept which we have to all understand in cerebral palsy. CP is not mathematics. Polio is mathematics. Okay, there are a lot of conditions in medicine which can be mathematics, but cerebral palsy is not mathematics. So when you see a child walking with knee bend, it is not necessary that it is because of a knee problem. It can also be because of a hip problem. Okay, this is something all of us have to realize. So if a child which is on the left here, and if I play his video, he is walking with knees bent, but if you see his trunk is upright, knee is not bent forward. So this is a child who has true hamstring tightness, and because the hamstrings are tight, the knees are bent. The only way he can walk is by bending the knee, because otherwise the tight hamstring will pull his pelvis backwards and he will fall backwards, right? So that's why he is walking with knees bent. If you see this child, he is also walking with knees bent, but if you see his trunk is forward rotated. And what is happening in this child is that in this child, it is actually the pelvis which is bent forward. Now when pelvis is tilted forward, it carries the hamstrings which are attached to the pelvis upwards. And because the hamstrings are carried upwards, there is a relative shortening of hamstring. Okay, and that's why the only way this child can also walk is by bending his knees. But there is a difference in their walking, the etiology of their walking. In the first child, the treatment is hamstring lengthening. Okay, if you lengthen the hamstring, he will walk straight. In the second child, if you lengthen the hamstring, the pelvis which is tilting forward will further tilt forward, and this child will actually stop walking. The treatment in the second child is actually to treat his forward bending of pelvis, which can be done by, releasing the flexors of the hip, or you can make him to do exercises where you actually bend the child backward, or you can strengthen the hip extensor muscles. So the treatment has to be on the hip, though the problem is in the knee joint. Sunil, we have heard this many times. In Sunday morning, when your wife is irritated at you, she shouts at the children. Okay, though she wants a change in you, the targeted therapy is on the kids. Okay, so this is something which we all need to understand. A child who is walking on toes, problem can actually be in the ankle. I've covered it many times here, that the child can be walking on toes because the ankle is in equinus, and Sunil has shown us that. But child can also walk on toes without any problem in the ankle if knees inflection. You can see here, this child walks on toes without any problem in the ankle, and he is walking on toes because the knees are bent, and when knees are bent, the heel gets lifted off, and this is known as apparent equinus. And in this child, if someone notices that heels are up and he is walking on toes and releases the calf muscles, again this child will stop walking. Okay, so these are very intricacies of movements. Ankle depends on knee, knee depends on pelvis, pelvis depends on knee depends on ankle. And this is something which we need to study, evaluate, and interpret, and then treat. Okay, so these are the and this comes only through practice. Okay, all right. Is this clear? This point to everyone? Some investigations we must know about. So this is child who is scissoring. Okay, and he has cerebral palsy, what is the first investigation you will do in this child? Anybody? Yeah. No. X-ray of the pelvis. Yeah. So when you see a child like that, okay, an orthotician, how many orthoticians are here? PNO, anybody? Yeah. Yeah, good, good. Somebody please raise your hand. Otherwise, IACD will remove you from membership. It has to be integrated society. Okay. Orthotician will think about providing an abduction brace. Okay. Physiotherapist will think about stretching the adductors. How many therapists are there? Physiotherapists. Yeah, many of them. Of you will think that we should stretch adductors and provide night splints and take care of this scissoring. Occupational therapist feel that probably there is a sensory problem, and let's work on this child's posture and tone and movement. How many occupational therapists are there? Yeah. So all of you will think like that. Let's also treat the tone and see if the adductors can be treated. Orthopedic surgeons will think of adductor release, right? And whatever is, release it. Okay. People who are rheumatologists and who are treating or neurologists, they will say, let's inject Botox in child's adductors and decrease the spasticity. If there is a neurosurgeon, they will think about doing neurectomy of the obturator nerve. So everyone will think differently. What people don't do is don't do X-rays of the hip. Okay, spastic hip disease is something which is very important. It's a silent killer. Silent killer. Even now, we see at least 2 to 3 patients every week where everything has been done for a child. The child has imported wheelchairs and stem cells and everything done, but somebody forgot to take an X-ray hip. And because X-ray hip was not taken, the dislocation was missed. So all of you can see that which side is abnormal. Just tell me. All of you. This is right and that is left. Which side do you think on this X-ray looks abnormal? Those who feel that right side is abnormal, raise your hand. All of you. Those who feel that left side is abnormal, raise your hand. So this is an issue that what your mind does not know, eyes will not see. Everyone feels that right is dislocated, but even the left side here is subluxated. And that's why we need to measure. We need to measure how much of the amount of the hip has gone out of the socket. So you can draw these lines and see how much of the head, what percentage is out of the acetabulum. And here this percentage would be almost 70%, but also on the other side, the amount of hip which is migrated is 6%. Now, those of you who cannot remember this, there is a hip screening app available on which you can just take an X-ray of the hip and the app will calculate the migration. Okay, so we can share this, the app with everybody who's here. So the one thing what we are learning and going is every time you see or you're treating a child with cerebral palsy, you're going to ask the parent, has the X-ray of the hip done in last 1 year? If it's not done, through appropriate channels, get the X-ray arranged and let it be seen. You can also, use the app and see the migration percentage, or let that patient be seen by 2 pediatric orthopedic surgeons which are here. And all of us have to work together to prevent hip problems in spasticity and detect early, treat early, so that we can avoid surgeries which are very, very big. The second X-ray we need when the child is walking with flex knee gait is X-ray of the knee, which is taken with maximum extension. This is something which is important. With the knee being straightened maximally, a lateral view of the knee should be done. We don't need AP view, just a lateral view. But it should be taken with knee maximally straightened. And in this child, you can see that this is the X-ray which is with maximally straightened, and it shows that the knee has flexion deformity. It also shows us many things. It shows here that the patella has gone up, patella alta, because quadricep is constantly pulling the patella when you are walking with the knee bent. On the other side, you can see that the patella pull is so much that it has actually caused a fracture of lower pole of patella. Can you all see that? Okay, on this side, you can see that the tubular tuberosity has actually been evulsed up. And this tells you that, this child can no longer be treated just with therapy or braces. It requires an orthopedic correction of this crouch gait. Right, Dimutu? I think this is what we were discussing, that patients come very late, and when they come late, it makes the job of orthopedic surgeon difficult, and it makes rehabilitation very, very difficult. So these all things need to be treated well in time. Okay, so this is about gait lab. So there have been talks about the gait lab. What I feel after having run a gait lab for 8 years, it's good to have a gait lab. It's better to have basic facilities. And if you have money to buy a gait lab, don't buy a gait lab. Use it on hip surveillance program. Use it for better orthosis. Use it, on wheelchairs. Use it on supportive devices. Things which are still not present in our countries. So it's good to have a gait lab. It is not absolutely essential to make a diagnosis of cerebral palsy or decide management. It is a research tool, and this is a tool many countries like Sri Lanka and India cannot afford. Okay, so we can, till that time we can have talks on the gait analysis, but it's important to do a very good visual gait analysis. Use a mobile camera in a slow mode and learn to do videos of children who are walking. So on top, what you see is how you see a child, recorded on an ordinary camera, and below you see something which is generated from a gait analysis. So it's like if you have this sport analysis, maybe you can have better batsmen. But it is better to have better coaches and better training facilities rather than having these fancy devices. Okay? So it's really not, it is good to have but not necessary. So, okay, all of you can see is walking with knees bent in the stance phase. In the lecture on gait analysis, we were told that in the mid stance phase, where leg on the ground, the knee should be completely straight. Now this child is walking with the knees bent. And when the child walks with knees bent, what happens is the steps become shorter. And though you may feel that he is taking a number of steps, the actual distance covered by the child is smaller. Okay, so that's the problem with flex knee gait. Now this child was decided by somebody that they were going to do hamstring lengthening for this child. Okay, so why hamstring lengthening was not required in this child is because when you evaluate this child and do his R1 and R2, the Tardo scale, in this child R1 was at 40 degrees, but R2 in this child went to almost 15 degrees, which meant that the spasticity window was almost 30 degrees. So Sunil, what would you do for that child? If R1 was 45 and R2 was 15, which means actually there was how would you interpret that finding in this child, and how would you manage that child further? 1-5. R1 was 45 and R2 was 15. And child had around 5 to 10 degrees of knee flexion deformity at the same.
Basically, spastic hamstring.
Spastic hamstrings.
Then you manage the spasticity by the method that
Absolutely. So this does not require surgery. What it required was injecting Botox in the hamstring, and because the child had flexion deformity in the knee, we managed this in an old-fashioned way by putting a plaster and doing wedging and straightening the knee. And this is now post-surgery, post-Botox and plaster. His knees are completely straight as the child is standing, and you can see that as he was walking, his walking improved. At the end of the stance phase, now his knees are almost straight and he is able to take longer steps. So for the same number of steps, you can see that he covers a much larger distance after giving Botox and plaster. Okay, so the treatment for this child was injection botulinum toxin, giving a plaster. After removing the plaster, giving him a night-time push knee splint, doing exercises to strengthen his quadriceps and exercises to continue to stretch his hamstring muscle. So this is in a very simple way this child was treated. So that's the decision for that child. This is a 10-year-old child. He is also walking with knees bent. In his case, he has knee flexion deformity of almost 20 degrees. And in his case, if you see the popliteal angle R1 and R2, R1 is now 70 and R2 is 60. So Dimuthu, in this case, how would you interpret this? R1 of 70 and R2 is 60. So that is static contracture of hamstring. So look at the spasticity interval. If R1 is 70 and R2 is 60, what is the interval between the two? 10 degrees. So spasticity is very little. This child has mainly contractures, so Botox will not work. Botox will not work in that child. What should be done for that child is to lengthen the hamstring muscles judiciously. God has given two hamstring muscles, medial and lateral, so we lengthen only medial hamstring muscles because hamstrings are also extensors of the hip joint. If you lengthen all the hamstring muscles, then the hip extension function of hamstring will be lost, and these are the children who come back to you, bending forward, walking with bending forward, and those who are not requiring a walker or a stick will now require a walker or a stick because now they tend to fall forwards. Okay, so this for this child, this is how he was before hamstring lengthening, and you can see this is how he is after his hamstring lengthening. So this surgery worked well, and if you have to see through a gait analysis, this was the knee flexion before surgery. This is the normal graph. This is how he was. So much of knee flexion before surgery, and this is the knee flexion after the surgery. So it improved because the decision making was correct. Now something which I want to show you is that this child was walking with hips flexed before surgery, and after surgery the hip flexion is normal. Okay, before surgery the child was walking with ankles dorsiflexed. After the surgery the ankle plantar flexion is normal. We have not done any surgery on hip or at ankle. Why did they improve? They improved because when the knee is in flexion, because of the liver arm issue, the hamstring become flexors of the knee, flexors of the knee. They do not act on the hip, and because hip extension doesn't happen because by the hamstring, the hips go in flexion. Once you correct the knee and knee becomes straight, the liver arm of the hamstring at the knee reduces. So hamstring automatically become poor flexors of the knee, but they become better extensors of the hip, and that's why hip also corrects. Similarly, gastrocnemius is the muscle which acts on the ankle and knee both. So when the knee is in flexion, gastrocnemius becomes a poor flexor of it, because he becomes a better flexor of the knee and poor plantar flexor of the ankle. Once you correct the deformity, the gastrocnemius acts better at the ankle and gives rise to this plantar flexion, and he becomes and it becomes poor knee flexor. What I want to say, if you don't want to remember all this, is that when you do a surgery at the knee, hip and knee also improve. Okay, so we see a corollary here. When there is a problem at the hip, knee becomes bad. When there is a problem at the knee, ankle becomes bad. But if you improve the problem at the knee, both hip and ankle can also improve. Okay, so that's what we've learned from this case. Now this is a child who is walking again with crouch gait. All are similar patients, but the strategy of management is completely different. He's a growing child, and in his case we see that the kneeling is good. So this is one thing which has not been mentioned in any textbooks. If the child is able to independently kneel, it means that he has good walking potential. And if you correct his knee and ankle, the child can independently walk. This is something you can tell the parent. But if child kneeling is poor, whatever surgery you do at knee and ankle, child will still require some walker or a support. Okay, so this is something which we need to tell the parents. And this child, again, there is a knee flexion deformity, there is shortening of hamstring, and when we did the X-ray of the knee, we realized this was this child's X-ray where there is excessive pressure and the knee is in flexion deformity. Okay, so here, because the knee has a flexion deformity, just lengthening hamstring is not going to work. We need to also correct this liver arm problem, which is knee flexion deformity. In a growing child, this can be corrected by stopping the growth of the lower femur from front. So we put these screws to stop the growth of the lower femur from front, allow the lower femur to grow from behind. So differential growth would correct the knee flexion deformity, and at the same time we did hamstring lengthening, okay, to improve the length of the hamstring. And you can see that this child was walking like this. Over a period of time he is able to walk straighter, and we encourage him to use a walker so that he is more upright and he doesn't regress into his walking pattern. So over a period of time you can see that just by putting these two tiny screws, his knee flexion deformity has corrected. This fracture also has healed and he is able to walk much better. So whenever there is a flexion deformity in a growing child, what we have learned that can be corrected by this method called growth modulation, where we use growth to correct the deformity. If you damage the growth, there will be a deformity. If you use a growth, the deformities can be corrected, but this can be done only in a growing child, typically a child between 9 to 11 years age. If the child comes later to you, for example, this child who is also walking with a crouch gait is using a walker, but again his kneeling is good, which means that he has good walking potential. Okay, in this child our strategy is going to be a little different. Here we are going to do an osteotomy, cut the bone, and when you cut the bone you achieve purposes together. We correct the flexion deformity by doing osteotomy of lower femur, but shorten the lower femur. When we shorten the lower femur, what is going to happen to hamstrings which are tight? They will loosen up. Okay, so the child will then become straight. What about the knee, the quadriceps which has become weak? In all these patients we have seen goes up, quadriceps become weak. Can you strengthen them? Yeah. You can strengthen them by tightening the quadriceps, by cutting the patellar tendon and bringing it down so that the patella comes down and that liver arm also improves. So it's not true that in cerebral palsy the only surgeries which do are muscle lengthening surgery. Sometimes we also shorten the muscles so that their power improves. Okay, so this is an example of a muscle shortening surgery along with the osteotomy, and you can see that this child is now able to stand straight. Okay, now when you do a surgery, lot of things change for a child. Someone spoke about international classification of function, ICF. All of you know ICF. So it's important not just to correct body structure and function, it is important to correct activity and participation. In the Canadian Cerebral Palsy Society, has replaced this ICF with 5 F words. I think all of you may have spoken about this sometime. So it's important that the function should change, but at the same time activity and participation should also change, and this child is a perfect example of that. He now is able to walk just with walking sticks. He can walk a kilometer, which means he doesn't have to be carried to the school. He was in a homeschooling program and now he can walk on his own to a place where a school bus can take him to the school. Okay, and he's an intelligent child. He studies well. Now he goes for school trips. He has a peer group, and I will show you perfect example of participation. When he's grown old, he's got, of course, boyfriends and girlfriends, and he's a very active social media user, has fan following on Instagram, and he is a jeweler by profession now. He designs jewelry, and also he has started a non-government organization to provide employment to people with cerebral. When you operate a child, the same child grown into adult has many facets, and this is perfect example of changing, impacting ICF, International Classification of Function. When people come to you very late, so this is a 16-year-old child who is adult now, almost an adult, and he is walking like this. Here also, some things will change. Of course, we do femoral osteotomy and put a plate, but instead of cutting the tendon, we bring the entire tibial tuberosity and fix it with a screw. So this is also a type of crowd correction surgery, which makes him to walk straighter and better. And this person is running his own business of mobile phones in a very small village in South India. So what finally it means that it's important, if you want to change the lives, it's important to take decisions which are correct. If your decisions are correct, your incisions will follow. So if your decisions are correct, ma'am, Sunil, Vimuthu and me will make right incisions and do the right surgery. And I want to end with this case. He's a child with a crouch gait, and again he was advised surgery. Surgery for lengthening hamstrings and patellar tendon advancement and osteotomy. Okay, so what is the final test which all of you will do before checking if this child really needs a surgery or? Okay, I am going to describe that test to you, which is making that child walk with A4. Now this is the same child walking with ankle foot orthosis. He is walking with knees completely straight. Now why was he walking with knees bent? He was walking with his knees bent because there is something known as ankle plantarflexion knee extension couple. Anybody knows about this couple? There are a lot of couples in Bollywood we know about, but this is one couple all of us to know about. And this couple is present because of a muscle called soleus. So when ankle is stable, soleus does not act at ankle, it acts on the knee by pulling tibia behind. Okay, when soleus is non-functional, and it happens most of the time because of a wrongly done soleal release, for a equinus gait, then these are the children who walk with flex knee gait. So one surgery wrong, soleal surgery, walking with flex knee gait, they will undergo hamstring lengthening. So second surgery wrong. Okay, so this can simply be treated by giving an orthosis, which is a rigid ankle foot orthosis. So any child, before putting him through surgery, I think all of us should check with orthosis and see what is the effect of orthosis on this child. So this child did not require any surgery on the knee. Subsequently, he required a subtalar arthrodesis. We did shortening of the gastrocnemius to repair his ankle, and then he walked much better than he was walking. Okay, so I'm going to end with this. Some of you may have seen this earlier. So when we are hungry, we require chocolates, which is like the knowledge, but we also require practical solutions, which are these dentures. And I'm sure we are now moving towards the practical solutions, and in post-lunch session, we'll utilize whatever we have learned in the morning session, and all of us together can start making decisions about what we are going to do to make the children with cerebral palsy achieve their maximum potential. Thank you very much.
Dr. Haral, I have a question where we have with very fibrous, tiny muscles. What do you like if you look at the gastrocs, like they are just like very thin strips of muscles and having this type of gait. I mean, when I saw the you were showing, except the older person, majority of them good bulk of muscle. So that is that a deterrent to decide whether they need surgery? I don't know.
So fibrous muscles are shortened muscles which are weak.
Yeah, we have very thin strips of muscles in majority of our cases. Children who come to us who are poorly managed, and
So here what we do is we start with rehab, and there are very lot of ways to reduce fibrosis in the muscle and stretch them up, and those are manual myofascial release. I think a lot of therapists must be knowing about it. So you can do it with hand, or there are devices, by which steel devices by which actually you can do a instrumented myofascial lengthenings by a therapist. So that will release the muscle slowly, and then you give them orthosis and make those children to stand. Standing is very important for children with C, whether it's MFCS 1, 2, 3, or 4. 5, it's very difficult to make them to be ambulatory or at least standing, but 4 you must make them to stand. And by use active and use of the muscle and gradual straightening, lot of improvements will happen. One more thing what we also do in these children is serial plasters to stretch the deformities and stretch the muscles and get them into active use. So it's possible to reverse a lot of this situation by simple means, addition of Botox and stretch plasters. So it's not going to correct the deformities fully, but it will allow you to improve the situations. And at appropriate time, you will have to do a surgical intervention in a very judicious manner, because you have to balance the shortening and weakness uh, and make that child to be more functional.
Couple of instances, only 2 instances like that. We have shown a child to Dr. Sunil, and then the child defaulted and presented after some time for surgery. That child we couldn't stand up because I think the optimal muscle power was not there by the time she underwent surgery.
Yeah.
Because my little experience, what I have found is the timing, and by the time you do surgery or any intervention, even for Botox, if the antagonists are not strong, when you release the agonist, then it won't give you the maximum results. So I don't know whether I have very little experience. So timing of intervention is also important. I have experience.
So I realize, one issue when I became a patient, which meant that the doctors come, they talk to you about your problem, but don't listen enough. So, typically when we take rounds of patients, we'll spend 5 minutes in the ward. I may have done a 5-hour surgery, but during rounds, we don't even spend 5 minutes. And that happened to me also. So then I realized that this is what must be happening to patients. That we diagnose cerebral palsy, we don't spend enough time with the parents and the child to explain to them what is the problem. We did a study recently through a medical student, and we wanted to know how much the parents know about what it is. And 70% of the parents didn't even know cerebral palsy and what their child actually has. They knew that there were contractures. Some of them knew that there is a seizure disorder. They knew that EEG needs to be done, medication. But why it happened, what is going to be the future of the child, they had no idea. And I think we are trying to, correct this situation by having people on board who are non-doctors, who will be counselors. Because typically we have everything but no time. So, number of patients we treat, if we cannot do, I have tried to circumvent in different ways. I made some recorded talks which are on YouTube, and we give those links to the parents about what is cerebral palsy, why they should do therapy, why surgery should be done in time. Short, and I think the association, I would recommend one project where you make your own YouTube channel, and in local languages, you make 2-minute videos about what is cerebral palsy, what is autism, and how the do's and don'ts of calf stretching, simple things. What is importance of weight bearing? What is important? Small videos which are on your YouTube channel. It's not going to cost much, but it can be done with a phone, and you have enough number of young people who will execute this. So I think it's a very simple project which should be taken to educate the parents so that these don't happen. Whichever patient is advised medication, surgery, plaster, botox, splints, if there is a person to check and call you back, like if you go to a car showroom, immediately you will get a call after 2 days. Doctor, you visited a showroom. When are you planning to purchase? Okay. What is your credit card? What is your salary? But when such an important thing happens, that child has cerebral palsy, from our side, no one calls up. If the compliance is fine. So I think these two things, if it can be done, a person who keeps check care of compliance and education, a lot of things can be prevented.
Thank you so much for that interesting and comprehensive talk. Can I ask a little bit about, I know you're most on the lower limbs and gait, but can you tell us a little bit about especially hemis and upper limb? What is the role
So
of
I'm going to
orthopedic
cover it tomorrow's talk,
Okay.
but I will say that in upper limb, surgeries are not very common. In lower limbs, we do surgeries, and I believe that that there is a difference of opinions among orthopedic surgeon. I feel surgeries, moment the child is developing contractures, I do a lengthening, which I do a percutaneous lengthening as early as possible, rather than waiting for full-fledged contractures. Okay, so we do surgeries early, Botox is early, we do a lot of bony surgeries also early, and this happens before the child is 7 or 8 years old most of the time. In upper limb, the surgeries are delayed, way delayed. We always will try with therapy, we'll try with Botox. Splints are underutilized in upper limb, but the proper splints are necessary for upper limb. The surgeries like tendon transfers and bony surgeries happen much later, at 12, 13, 14 years age group. So that's how the timetable in upper limb changes. The problem in upper limb is mainly sensory. It is that the kids don't even know that hand exists. So they don't use it. And that's why, it was very nicely mentioned about strategies for upper limb like constraint induced therapy. And so these all things actually remain in the books and lectures, and very rarely you get to practice it. But intensive, you have to provide some reward to the child to use a hand which is, so we have used these methods, like rather than punishing the child by putting a plaster on the other hand, if you give a reward to the child in form of stars or reward points for using this hand for 2 hours, the weak hand, and those reward points can finally they can be exchanged for something which the child likes. So reward rather than punishment works better. So these are few of the things which we use in upper limb. We also have, like gait analysis, we have a video recording score of the upper limb which is known as a Shui score. And in future, if we have a workshop, we would like to discuss this Shui score and train all your occupational therapists into using this Shui score into decision making for upper limb. So these are few of the things we do for upper limb. Anything else for upper limb, Vimuthu or?
Yeah, as you said, it's mainly the maybe because the muscle bulk is also less in the upper limbs compared to the lower limbs, and that is why they don't give up that much of shortening and then contractures so frequently. And then it's mainly the stretching, splintage, and then I have done a couple of there's a pronator contractures. I have done pronator teres release. Other than that, can't remember doing that many surgeries in the upper limb. And
So that's a dystonia.
Is dystonia.
Yeah, and not
they have a lot of
not-
sensory and dystonic.
Yes.
Real contractors.
Right.
Yeah, the most difficult ones I have faced it, yes, with dystonia. So the starts doing things, they become all of a sudden that exaggerates and all that. Myself, Piara is not there. We have that because books don't explain Botox to dystonic muscles, but we have tried a couple. Yeah,
Can be
we have tried a couple, carefully select what to inject on trigger muscles, and then we have had results with them. But I really don't know. I have nothing to compare with. So I really don't know whether the decisions I make is correct or not.
We use. And upper limb, one more thing is people look at pronation, supination, they look at the wrist, but they often forget the thumb. Thumb, see, if to pick up anything, the spread of thumb is very important. If you have a thumb like that, don't use it. Yeah. So it's important to splint the thumb in this position from a very early age. And upper limb splinted should be 8 to 9 hours. It should not be full time. The children will not use splints, like big splints should be thrown away. We use very minimalistic splints. I'll show you some of the pictures tomorrow in the talk.
And
thumb splint should be minimalist.
whatever we do should be followed intensively by therapy, which is very difficult to get in our context. Parents understand, and then there's the distance and the lack of therapists, and all it is there.
So
it's difficult.
intensive therapy. What do you mean by intensive therapy? It's a question. In Australia, when I went, I was shocked that intensive therapy was twice a week, and a regular therapy used to happen once a week or once in 15 days. And because to give in Bombay, some of the places, intensive therapy means 3 sessions of therapy in a day. It's really too much for therapist and the family both.
And I usually tell them, teach to drink from a cup. First try to hold it, and then to put it in another place, lift it up and try to correct the pronation, and then put a little bit of water and bring it up as the child is able to
One more thing which we use very little, all of us, are assistive devices. If a child can hold a mug, can you make a mug in such a fashion that child can hold? You cannot change the child's grip, fine. But can you make a mug in such a way that child is able to? Can you make a pencil in such a way? Or can you make a bottle in such a way that child is able to open the cap? I think it's possible to do.
So one more question is there.
My question is also related to the crouch gait. I mean, when we assess children with crouch gait, we have noticed that the weakness is mainly present in the soleus and also the hamstring and the hip extensors. My question is, if we are going for a surgical intervention like hamstring release, how much muscle power that the child should have for the hamstring and hip extensors, and also what we can do for the weakness of the soleus.
Right.
And also one more question, sir. We have also noticed that they have mid-foot break.
Right.
And if you go for surgical intervention, should we address all those things?
So I'll answer these questions one by one. In cerebral palsy, it is very difficult to ascertain muscle power. It's not easy. In you and me, we can check muscle power very easily. In child with cerebral palsy, because of cognitive issues and because of lack of selective motor control, it's very difficult to ascertain a muscle power, and that's why it should be more functionally checked. Like, is the child able to lift himself from a sitting position? Then soleus is working. Okay, so that is how we check it. Secondly, it's very important that before Dimuthu and Sunil, they operate the child, there must be a 3 to 4 months of prehab. All of us know about rehab, but prehab is also important. rehab is preparing the child for surgery. So all our crouch gait patients, we of course, make them to stand with push knee splints before surgery. What happens in a child with crouch is because hamstring is powerful, hamstring becomes hip extensor. And that's why the glutea are very weak. Because the child has never used them. Child's brain doesn't even know the existence. So it's in a unit, ma'am. If one resident is working very hard, the others will not work. And their existence we don't even know. We only realize the importance when if you have a resident who is a girl and goes on a pregnancy leave and the other resident has to work, we suddenly realize they are not prepared to take up that work. So what you will do is train the other resident before the girl who has to go on leave actually plans a leave. It has to be planned much in advance. So similarly, hip extensor should be separately in an isolation. You have to dissociate that muscle and train them for at least 2 to 3 months before you do hamstring lengthening. Okay. So similarly, soleus can be strengthened by manual stimulation, electrical stimulation, functional usage of the muscle before you undertake a gastrocnemius procedure. Because gastroc is more powerful, soleus becomes weak in cerebral palsy. So these things happen. Midfoot break, that was the second question. It is part of the problem and hence it has to be also part of the solution. So whenever you have a midfoot break, you have a liver arm issue, your foot length is not put to use. Only half of the foot length is generating pressure and hence soleus cannot work. So if you do a crouch surgery without addressing midfoot break problem, then the crouch will recur. So how do you address this issue? Either you do the knee surgery and use a solid ankle foot orthosis so that the midfoot break is not a problem. But if you want to get rid of orthosis, you will have to address the midfoot break through various foot surgeries. And I've not included those in my talk, but I'll add those slides so that I can include the Moscas procedure and triple fusion both as part of the solution for midfoot break. I'll add it tomorrow.
Thank you very much, sir, for your very interactive lecture on orthopedic management in cerebral palsy.
දරුවා එකමදේ නැවත නැවත කිරීම සෙල්ලම් බඩු එක දිගට තැබීම ඕටිසම් තත්ත්වයේ ලක්ෂණයක් විය හැකි. ඕටිසම් ලදරුවියේදීම හඳුනාගතහොත් හොඳින් පාලනය කළ හැකි. නොපමාව අමතන්න 11490.3 SLACD සහ CDB සාමූහික මෙහෙවරක්.
If your child focuses on things in a repetitive or obsessive way, it could be a sign of autism. Autism can be successfully managed if identified at an early age. Call our helpline on 0117490000, a joint effort by the SLACD and CDB.
குழந்தை மீண்டும் மீண்டும் ஒரே செயலை செய்தல், விளையாட்டுப் பொருட்களை ஒரே வரிசையாக அடுக்குதல் ஓட்டிசத்தின் அறிகுறியாக இருக்கலாம். ஓட்டிசத்தை சிறு வயதிலேயே இனங்கண்டு கொண்டால் அதனை கட்டுப்படுத்தலாம். தாமதியாது அழையுங்கள் 0117 490 0000. இது SLACD மற்றும் CDB இணைந்த செயற்திட்டம்.